Welcome back to County Conversations. I'm your host, Stephen Acquario of the Association of Counties, and today I'm joined by David Lucas, the NYSAC Director of Finance and Intergovernmental Affairs. Dave, thanks for joining the show.
No, it's great to be here. Thanks, Steve.
Really appreciate it. Today we're talking about changes in the Congress. Been in the news lately, Dave. The Congress trying to reduce expenditures of the federal government. New York State is a donor state. We send a lot more money to Washington, D.C. than we get back from Washington, D.C. How long has that been going on?
Well, historically, that's been the trend. During the COVID years, we were a donee state. We actually collected more for a couple of years there. I think next year, when they do that analysis, we're going to be back into the negative. But it was $18 to $20 billion per year.
That we send more to Washington.
More federal money goes there than comes back to the state. And there's different ways to measure how the money comes back, but we were in the hole for just about forever, since the 70s when Senator Moynihan started doing the analysis. We were always negative.
They are considering cuts. The Congress has been on a recess right now, an Easter Passover break, if you will. They are back at work right now. We're talking about Medicaid today. This is about Medicaid. New York State is a state that has a population dependent on Medicaid. How many New Yorkers are covered under the federal Medicaid program in one way or another?
Yeah, I'd say about a third of the state population is in the core Medicaid program. We also have another 7 or 8%, maybe 10% that are getting health coverage from the Affordable Care Act and some of the expansions and the credit subsidies they provide there to lower the cost of insurance. So we're looking at 44 to 45% of the state population in some way getting their health coverage through Medicaid or the ACA, the Affordable Care Act. And those are federally subsidized and state subsidized and local, because in New York, counties pay part of that cost.
You're talking 7 to 10 million people.
Yes.
That is a large demographic
Yes.
of people. In some cases, it's more than the entire state population in some of the states that are controlling the rules. Dave, I've heard the Congress talk about numbers that are pretty big. The what they call offsets or funding cuts, reductions in spending to pay for other priorities set, of course, by our president, set by the Congress themselves. They have to figure out what's called an offset, or a way to pay for that spending. You can either raise taxes or increase revenue or reduce expenditures or cuts. The numbers that I've seen, anywhere from $600 to $800 billion of funding cuts, that's a lot of money. How do these cuts affect Medicaid, and where are we heading in this with this discussion right now?
Yeah, we need to put that into a little bit of context. The 6 to 800, maybe 900 billion, that's a cut just likely to come out of Medicaid.
Oh, in one program alone.
That's the target for that one program. Congress's target is to offset about $2.5 trillion over the next decade. And the primary reason they're looking for offsets is they want to extend the tax cuts from 2017 under the first Trump administration. They have some other tax things they're looking at. They want to do other tax reductions. And they also want to increase spending in some other priorities. They want to increase money for defense programs over the next decade. They want to increase spending for border security and immigration reform, and also for more energy exploration and incentives to do more oil and gas exploration within the United States. And even probably some green energy too might be part of that process. But those spending priorities set by the president and his campaign and pushed by the House and Senate at this point, that's the reason they need to do the offsets, because otherwise it just increases the debt just too much. And we currently have about $36 trillion in federal debt with an interest payment each year of about $1 billion right now, or $1 trillion. And that's bigger than the entire defense budget. That's bigger than all discretionary spending the federal government does. It's bigger than Medicaid spending. It's bigger than Medicare spending. That's interest on the debt. And that's why they're so concerned about moving things forward and not offsetting the debt, because it's just becoming unaffordable and it's becoming the biggest expenditure in the federal budget or could.
Why should county leaders care about what's happening in Washington, D.C. right now with respect to Medicaid?
Yeah. So
Why?
Yeah, in Medicaid, we're a payer. Under state law, we're one of the handful of states where the state mandates counties put in a contribution. We put a contribution in of $7.6 billion every year, and that's from New York City and the 57 counties outside New York City. And it was set a while ago. We used to pay like 50% of the non-federal share, so we would share it even with the state. And then in the 2005 area, they set up a cap because of the Medicaid expansion that happened in the early 2000s was just so expensive. We saw counties doing double-digit increases multiple years in a row in property taxes, plus increasing their sales tax from 3 to 4% to pay for the Medicaid expansion. It was just so expensive, and the state legislature realized, well, this can't go on. So they capped our liability in 2005. It had a set, 3% growth rate going forward, and then again in 2012, when they did the real property tax cap under Governor Cuomo capped our growth at a 0% rate at that point in time in 2012, which really went into effect in 2015. So since 2015, we've had a capped amount. That's been offset a little bit, and we'll talk about this a little bit more later. Under the Affordable Care Act, there was some enhanced federal match that came in to do expanded coverage for people just above the poverty level. And in New York State, that funding was shared with the counties. But a couple of years ago, the state legislature and the governor started taking away that extra resources that came to the counties. It's something that really was beneficial over the last decade. We lost all of that funding as of April 1st this year, but it allowed a lot of counties to maintain their levies, keep them flat. And I would say today that almost every county in the state has a lower tax rate than it did 10 years ago because of that federal money coming in, but it's gone at this point.
Well, clearly we have a relationship. Clearly there's a lot, Dave, at stake with these discussions.
Yes.
I heard Representative Bacon from Nebraska come out a few days ago saying that initially he was not supporting benefit cuts in Medicaid, but now there was a statement that he would accept up to $500 billion in cuts in Medicaid. Look, let's unpack this a little bit because New York counties are involved in this because we administer this federal health care program. We are these, in our social services departments, we administer Medicaid. So any adjustments made by the Congress, made by the federal government, through the state of New York could have a real and meaningful impact in New York for New York County governments. You've identified 4 issues, 4 buckets, if you will, that you're tracking. Let's unpack them one by one. The first is the enhanced FMAP, EFMAP, that of course stands for an Enhanced Federal Medicaid Assistance Percentage reduction, or some sort of per capita spending cap. Take a few minutes, Dave, and explain to our listeners what is an FMAP, what is an enhanced FMAP, why is that important, and why are they looking at that in Washington?
Yeah, this EFMAP is particularly related and linked to the Affordable Care Act that passed in 2010 and went into enactment in 2012 and 2013, around that time frame. And what they were trying to do was expand health insurance coverage nationwide. So at that time, we had a national uninsured rate of probably hovering around 16% in 2010. Today, it's hovering around 8%. So it basically cut it in half. And the way they did it was they targeted the population just above the poverty level. So we're talking about people that are at no more than 138% of the federal poverty limit. And for a family of 4, that's about $44,000. Most of those families work. The issue is they don't have health coverage through their employer, or it was insufficient. The problem is, health insurance costs about $25,000 a year. That's a national average. In New York, it's probably quite a bit higher than that. It's probably hovering around $30,000. So when you're earning $44,000, buying health insurance is just not possible on that low end of the income scale. So that's the group they were targeting. So what they did is they enhanced the federal share of funding to target that population to make it easier for them to get coverage and not burden the states with this new expense. So
Was it temporary? Was it permanent?
it's a permanent feature. A state had to opt in, and if you opted in to do this expanded coverage, the federal government said, we'll pay 90% of the cost of each of these people, every enrollee, through the Medicaid program. And they just used Medicaid because it was a model that was available, and it just made a lot of sense. The networks were established, the doctors and physicians and other groups were already in it, they were familiar with it. Very, very low administrative costs in that program, as well as Medicare, because you don't have all these intermediaries. It's a direct payment program.
Did New York opt into it?
New York opted in right away. And part of the reason New York opted in is they had already expanded coverage to a big chunk of that population. So that's part of the reason we actually got a cash benefit from the ACA passing. New York did. So the state got a share of money as a reduction or an increase in the federal government's cost to us, and that was passed through to us as cash or a lower payment we had to make to the state to pay for Medicare. So it was highly beneficial.
What's at stake here, Dave? How much are we talking about? Are we talking about $500,000, $1 million? What's the potential 10-year impact based on these discussions in just this one program?
Yeah, so just for New York, it would probably be about a $70 billion loss of funding.
Billion
Yes,
dollars.
over 10
That's
years.
what's at stake.
That's what's at stake for this program. There's two things that Congress is talking about. They want to take, in our case, every state's got a different percentage the federal government pays. We're at the lowest possible.
50?
50. That's the lowest you can get from the federal government.
States with higher poverty, like say Missouri, would be at a higher level, maybe 90%, where we have wealth and poverty, so we're at the floor.
Yeah, we're at the floor.
Okay.
And actually, if we didn't have the floor, our match would be even lower. But there's two things they're looking at. They want to reduce that 90% increase they did under the Affordable Care Act to some lower level as a way to save money. Another thing they're talking about is doing a per capita cap within that program. So the way a per capita cap would work at the federal level, there's a lot of different ways you could implement it. But in general, you would look at each state, how much money are they drawing down from this program, how many people are in their how many people are you serving, and that's going to come out to a statewide dollar amount. And they're going to say, this is the amount of money we're going to let you spend going forward, and we're not increasing the federal share anymore. So they sort of get rid of the 90% share, but they cap it at that dollar amount, saying you can't go over it. That's one way to do it. And that's another way they could do it is they could use that model, create a current level baseline, and let it grow each year, and saying the federal government will kick in 1% increase each year. Health coverage and health benefits, the inflation rate's about 4 to 5% per year. So if they put in a 1% sliver, you kind of fall behind the dial. In a more worst case scenario, they could look and say, what's the average nationwide on a per capita basis in this program? Well, we're probably 75% higher than the national average. So something that would link back to the national average, that would be very devastating for us. So we would probably lose all of that $7 billion. And clearly the state and the local governments can't handle that at our level.
So what's the message to the New York congressional delegation? We used to have 45 members of the Congress representing New York. We only have 26 now. What do you want to tell the 26 members of Congress? And of course, our 2 United States senators.
Yeah, I think we need to tread lightly here and carefully and reductions on the Medicaid side. I mean, there are some things.
Their people's lives are at stake.
Yeah, there's a lot of people covered. Like you said, it's 10 million people in New York. At the end of the day, whether we lose $1 here in federal assistance, it's $1 we can't spend on health coverage in the state. And when you start getting into the billions, there's no way the state can do that without significantly raising taxes. And as I said earlier, we're a payer. The state could turn around and say, you know what, we want local governments to pay more. And that would increase property taxes because that's our main source of revenue at the local level when we have a recurring expense. So that doesn't help moving us forward under this scenario. So we've suggested other things. We would like to see more aggressive action on the pharmacy benefit side, on the prescription drug side, more benefits to lower the costs there. Waste, fraud, and abuse, eliminating that as much as we possibly can. There's
Right.
some things we've targeted in the past, and Congress wants to go after those types of
As
things.
they should.
As they should,
All right.
absolutely.
Let me talk to you about taxes. There's something as part of this discussion that's occurred in our state called a provider tax, a healthcare provider tax. Of course, it has to be for a Medicaid institution only. This is a tax that's levied upon a healthcare provider. Why is this under review right now by the Congress? And why is it important to New York counties?
Yeah, so New York raises between $5 and $6 billion a year between healthcare provider taxes and assessments and some fees they charge that just basically get built into the cost of providing health coverage. So if you tax a healthcare provider, they're going to build that in as a cost of doing business. The way it's worked in the past, and these taxes have been around for over 30 years. Starting in the 1990s, they were available.
Approved by the federal government.
Yeah, approved by multiple presidents of both parties. It doesn't matter. They've gone through. These have been used, in 1115 waivers. These broad-based waivers states do. They've allowed them to do things here, and there's a pretty strict formula the federal government uses to make sure that these taxes are applied uniformly across providers. You can't just pick on Medicaid providers and say, oh, we're only going to tax Medicaid providers, because that they know that would be unfair, because then the government puts in the match on the dollars raised. So it has to be against all providers. What's happened over time is some states have figured out a way to, I wouldn't say manipulate the formula, but leverage it. The models, the mathematical models the federal government uses, to the point where 90% of the tax or 95% of the tax is being targeted towards mainly Medicaid providers and Medicaid enrollees. So the federal government's saying, well, that's not what we really intended. You can tax healthcare providers and we'll match it at whatever the matching rate is, but it needs to be applied to all providers across the system. So they want to really get at the manipulation of targeting the tax to Medicaid reimbursement, because the way the providers are left unharmed for the most part is they raise Medicaid rates and they use the federal money to pay the Medicaid rate back, which helps the providers because they need more resources too. There's a lot of them that are struggling out there. But that's something they're going after. So if they give that a haircut or they eliminate that possibility, that's another $5 or $6 billion you could look at. The other thing about these things, we don't know what they're going to do precisely. Are they going to do, like a per capita cap, or change the FMAP in the ACA, or just change the FMAP overall, your base FMAP, provider taxes, waste, fraud, and abuse. We haven't talked about it yet, but they're talking about doing a work requirement. They could do all of these things at different levels of scale. So they could do one or two big ones.
Right.
Or they could do a combination of these in a bunch of little ways, and that would have varying effects across the country, because different states utilize this program differently. Like the ACA FMAP change or the per capita cap, 10 states never expanded this program. They would have no fiscal impact at all in their programs. So there's a lot of different ways Congress is looking at this, and I think at the end of the day, there's a lot of members in the middle are saying our constituencies like having health insurance.
Right.
And there's a lot of these, even on the Republican side, where 40% of their residents in their congressional district are on Medicaid or ACA.
Well, I think it's important for
So-
members of Congress to understand their district, right?
Yep.
Who's on benefits, what are the providers in their district, and
Yeah.
truly understand how this one program called Medicaid impacts their congressional district. Dave, let's talk about work requirements. Counties right now, again, we are departments of social services. We are providing these federal and state programs to the public, and we administer them. So if the federal government wants to expand a population, we're already subject to, I would think most people are already working, Dave, that are on Medicaid. True?
That is the
Okay.
case, yeah.
So they want to expand the population that might be subject to new work requirements, which would necessarily mean that we have to track that. Would we have to pay for that? Would we have to hire additional staff? What is this work requirement issue that's being discussed?
Yeah, so what we're really talking about here is what they call the able-bodied population. It's adults that don't make enough money to have a job and they don't have health insurance. What they find statistically, I mean, there's people that are disabled or the elderly that, this doesn't apply to them. It would apply to this able-bodied population, which is a pretty big number in New York. We're talking millions of people in New York would fall into that category. We do some work requirement things now, but it's a really small sliver of the population. In New York, this is a function that would probably end up falling on the counties based on how our system works. And it depends on how stringent the work requirements would be. So, for example, they would want to say, are you working at this point in time? And if you are, you check the box, you keep your eligibility for Medicaid. Let's do these checks on a quarterly basis. Every 3 months, we're going to check to make sure you're still working or what your status is. And as long as you're employed or working towards employment, like in a job skills training, or you're in college preparing for a career, we'll cover, you're going to keep your Medicaid eligibility. Right now, that's kind of done on an annual basis. But it's, like I said, it's at a very small sliver of the population. Expanding that to millions of people, a big chunk of that would be New York City, but even the counties upstate, they would potentially have to hire hundreds of people across the state, maybe even over 1,000, or contract it out to somebody. Because, if a person is not working, you got to help them find a job, or getting them into skills training or some sort of education program so they can eventually work their way to that point. That's a very time-consuming exercise. There's a lot of paperwork involved in this process. You'd have to verify payroll stubs and things like that. The state might be able to do some of that at a very high level through withholding that's at the state level. But a lot of this would be people walking into the local DSS saying, I'm here for my quarterly check on my work to verify that I'm working. Here's a payroll stub. Someone's got to track it all. They got to enter it into the system. It's just very time consuming. They've done this in a few states through waivers in the past, and what they found was a very high rate of people dropping off the program because it was very burdensome to maintain all the records and do that on a recurring basis. It was just part of the system. It was administratively burdensome for the entity doing the collection, and it was burdensome for the clientele that was going in every quarter or however often to prove they were working or working towards finding a job.
We've been joined by David Lucas from the Association of Counties. There's 4 issue areas that we are tracking on behalf of the New York counties. Of course, the Enhanced Federal Medicaid Assistance Percentage, or FMAP, work requirements, provider health care taxes, and of course, fraud, waste, and abuse. Those are the 4 issue areas. It sounds like, Dave, New York counties have a lot to contribute in this discussion. I want to thank you very much for joining us here today.
Yep. In a closing comment, any federal dollar cut is going to impact coverage somewhere in the state, or we're going to have to replace that coverage. When people lose coverage, because counties run DSS offices, they're going to walk in our doors looking for assistance. Like, I lost my health coverage, I can't buy my prescriptions, I can't afford them anymore. They could, have an incident with their health or their mental health. That is going to increase dramatically as people lose health insurance coverage. That's something we need to remember. And the final note is, with less federal money into the system, we've got a lot of healthcare providers in the state that run at a deficit. They're losing money every year. The state tries to prop them up through disproportionate share payments, which the federal government helps in, or bad debt and charity care. That pot is potentially going to get bigger because there's less money in the system to help pay providers. So it could limit health care locally, regardless of whether you're a Medicaid patient or not, because this is going to be a tough issue in rural areas already. We see way too many providers close or hospitals close. during the Medicaid expansion and the Affordable Care Act, for that 10-year period, the first 10 years that happened, over 100 hospitals closed. And that's in a period of expansion of health coverage because their fiscals just didn't work. If you clamp down on the availability of resources in a system, it's probably going to get worse. So that's something we need to remember in this situation. It's just not about Medicaid. It's about health care in your entire community.
Real lives at stake for real New Yorkers. David Lucas, thanks so much.
Thank you.